excited. All right, so moving on to a much happier topic. It's really a great pleasure for me to introduce Dr. Virgil Dalm, who is an MD and PhD out of Erasmus Medical Center in the Netherlands. I know that many of you are familiar with Virgil. I think, what has it been, about 15 years now since you've been part of this group? Amazing. So Dr. Dalm is a physician and researcher specializing in clinical immunology and primary immunodeficiency, otherwise known as PID, at the Erasmus University Medical Center in Rotterdam. He focuses on identifying genetic defects underlying PIDs to develop targeted treatments. He also investigates underreported complications of PID, including skin, endocrine, neurodevelopmental, fertility, and psychiatric disorders. His recent interest lies in understanding the link between PIDs and neuropsychiatric complications. Dr. Dalm envisions leveraging genetic defects to create better treatments for PID patients. And I can tell you, unfortunately, Ken Paris, his partner in crime from New Orleans, was not able to be here today. So Ken was able to go to the European conference. Virgil wasn't. Virgil was able to come to the American conference, and Ken wasn't. But you know, this is what is so great about this group. They are doing this on their own time. And as you'll appreciate if you haven't heard already, what an impact their work and just becoming so accessible to all of you have made to lead to literally life-saving interventions, which I think some of you can already attest to. So without any further ado, let's give a warm welcome. Wait at least till after that starts.
Yes, thanks, Paul, for the introduction. Of course, thank you, Lindsay, for this invitation to be here again. Well, been here a couple of times, or a few times indeed. I think we go back to the early 2012, maybe 2014 edition that I was here first. And I think, like Paul said, it's a great community, and also the professionals that I'm working with. It's lovely to see that it is still this, let's say, team that is focusing on improving care for people with LFQ disorders. First, you have to remind me that I have to be here because it's in front of the camera. I have to. I always try to move around a bit when I do presentations. So if I get out of focus, please put me back here again. And what I would like to talk to you about today is the immune system, and the immune system in relation to what we call, let's say, a bit broader LFQ disorders, of which, of course, Jacobsen Syndrome is one example. So just to give a brief introduction on the immune system for a better understanding of the rest of my talk, this is how we see the immune system, like an umbrella, giving you or providing you protection against the, let's say, outer world. So our immune system is there to protect us against bacteria, viruses, fungal infections. So microorganisms don't need to be, or don't need to be in your body. So this is a bit more complicated picture, but just remember the umbrella: protection against the outer world. But for the sake of this presentation, I think it's very important to see that the immune system is a very complex system, comprising different cells and different proteins. And as an example, I think over the past years, a lot of you have heard about B cells, and of course, what B cells produce: antibodies. In COVID times, we were all talking about vaccination, induction of antibodies that should protect you against getting sick from COVID-19 infections. So the B cells produce antibodies, and these antibodies are very important in preventing infectious disease or infectious complications. We also have neutrophils that eat bacteria, and T cells that fight against viruses and fungal infections. But just as an example, number of cells that are involved in our immune system protecting us against specific infections. So the important message from this slide is that we have a lot of different cells, all with their own unique features and unique functions. So B cells producing antibodies, fighting bacterial infections, T cells fighting fungal infections. So all these cells have their own function. And in our normal conditions, the immune system should be in balance, like shown on this picture. If there's an imbalance, if there is a balance in the immune system, your immune system works properly, there are no serious infections, and on the other hand, there is no autoimmune disease. So in the perfect world, the immune system keeps a balance, which results in a healthy clinical state. No severe infections on one side and no autoimmune disease, because if your immune system is overactive, you may have autoimmune disease, and we'll come back to that later. So what if something goes wrong? And I think this is a very nice example. This is actually an umbrella with holes in it, showing defects in the immune system. The umbrella is made by a patient of mine who is suffering from an immunodeficiency, and by selling these umbrellas, he raises funds to perform research on very rare immunodeficiencies. But I think the umbrella nicely reflects what can go wrong in the immune system, and like you see here, there can be holes in their immune system, and the holes can be in different places. And remember, all these cells having a particular function, it depends on where is the hole, what kind of problems you encounter. If the hole is, let's say, in the B cells, you may have different infections than when the hole in the immune system is in the T cells or the neutrophils. So things can go wrong in the immune system. It can go wrong in several places, and depending on where the problem is, you get specific clinical problems. So this is what we are looking at. So an imbalanced immune system, and it can go wrong on both sides. So if the immune system is too low, doesn't work well enough, you have an increased number of infections, makes you vulnerable for recurrent infections. And on the other side, this is a bit of out of scope for today, but just an example, if your immune system is overactive, which means it fights its own body, a component of its own body, you get autoimmune diseases. So the immune system attacks parts of your own body. And just some examples of autoimmune diseases, because we won't go into detail today. For example, rheumatoid arthritis, joint disease, or psoriasis, skin disease. Those are common autoimmune diseases. So the immune system starts attacking joints. Rheumatoid arthritis or starts attacking the skin, psoriasis, giving damage to the joints or results in skin lesions. So these are examples of the immune system being overactive. So back to the immune system. So this is our normal immune system. Like I said, composed of different components, various cells, various proteins. And just to give a bit of in-depth information on the immune system, this is actually what it should look like. Actually, the Dutch team is now playing against Austria at this time for the European Championship football in Germany. And what you need, if your immune system works properly, you need good players, but also in the right position. So just as an example, how the immune system should work, you need all the cells, all the proteins, which should function well, but they also should be organized very tightly. And so there is interaction between the cells, and the proteins. So you not only need all cells or proteins, but you also need them to be aligned, like, let's say, a football team. Another comparison, because it was funny that Paul mentioned it, was something that I showed many years ago, because I usually, in the past, when I was talking to students about the immune system, I used to compare it with the perfect marriage. Because if you look at our immune system, there are some functions or positions that you need to take, like in your marriage. So the immune cells should complement and support each other. Because if one system or one part of the system falls down, another part of the system should be able to take over. Because like I'm here now, not all of my immune cells are working the same. Some are more active, others are less active at the moment, just to keep that balance. So there's an overlapping function, because if a part of the immune system breaks down, another part of the immune system could and should take over to prevent you from serious infections. Like already mentioned, immune cells should act together. B cells interacting with T cells, B cells producing antibodies to get rid of infections. Of course, very important, the immune system is involved in eliminating intruders, bacteria, viral infections, fungal infection should be removed from the body. And very important aspect, and that's something that we will discuss in more depth today, is the immune system should be able to learn. Because when I get sick now, for instance, from severe pneumonia, hopefully and normally, my immune system will fight the bacteria. I can be sick, but I will recover. And when I encounter the same bacteria in 6 months from now, my immune system should have been able to build memory so that I won't get sick from the same infection over and over again. So in normal conditions, yes, you can also get infections, of course, but as the immune system is able to learn, repeated infections with the same pathogen, with the same bacteria, usually don't occur or usually don't give rise to recurrent severe infections. And that's something that maybe you recognize in your kids, that they can have infections over and over again with the same bacteria or same fungal infections or viral infections. So there seems to be a problem with the ability to learn, to build up memory in the immune system. Very important, like already mentioned, the immune system should differ between what is cell and what is not cell. So the immune system should fight infections, but should not start fighting body parts, like for instance the joints or other cells. And also the immune system should be tolerant for things that are not dangerous. What we're talking about then is allergies. So allergies are examples that your immune system starts fighting goods that are not dangerous. For instance, pollen, for instance, cat, dog, hair, whatsoever. Those are not harmful, but your immune system is reacting against. But as we all know, or many of you know, that the perfect wedding or the perfect marriage does not exist. So unfortunately, things may go wrong. And what can go wrong, summarized over here. So if this part of the immune system or this part of the comparisons is not working, you get an immunodeficiency. The immune system not working properly, giving rise to infections. And here are some examples of autoimmunity and allergic complications. So just briefly introducing the immune system, the specific part of the immune system, the role of the immune cells, the complexity of the interactions, and back to. So the question is, to have this umbrella, to have this protection, what do we actually need? And I think three different cells I would like to discuss today because of what we see in people with latitude disorders. So these are neutrophils, phagocytes, monocytes, macrophages. They all called different kind of names, but these are eating cells. Why are these important? These are stupid cells because they are not able to learn. They were just fighting infections once they encounter bacteria. So just to show you an example, so this is the neutrophil. This is the cell, this is the bacteria. So the neutrophil, when the bacteria enters the bloodstream, starts chasing this bacteria. And it's just recognizing bacteria as being foreign. So it knows the bacteria should not be here. So I start chasing him, and you see here, it eats the bacteria. So this is actually your first line of defense. When you get a bacterial infection, the neutrophils become active. They start chasing bacteria and start eating bacteria. This is very important because when you get sick, these are the cells that act first to fight bacterial infections. The problem is they do not build up memory. So this happens over and over time upon every infection, but every time bacteria enters the bloodstream or the lungs or whatever the infection is, the neutrophil starts doing the same over and over again. So it's the first line of defense. It starts very quick. It doesn't build up memory. So to build up memory and to prevent you from recurrent infections, you need these cells. forget the pictures. I just want to briefly demonstrate that there are two different important immune cells that we have to remember. Those are the T cells. Those are particularly involved in clearing fungal infections and viral infections, virus and fungal infections. And like I already said, if cells interact with each other, the T cells are very important in activating and supporting the B cells. And for today, these are very important cells that we need to discuss. B lymphocytes. Already shown in one of the first pictures, the B lymphocytes produce antibodies, and those antibodies look like this, like the Greek letter Y. So those are antibodies that can find and let's say attack bacteria. So this part of the antibody is directing against different bacteria. So it's able to find and adhere to bacteria, like shown on this picture. So this is the bacteria that goes around in the bloodstream, and those antibodies, they can specifically recognize bacteria. And I have a short movie showing what is going on. So this is the bloodstream. So a lot of white blood cells, red blood cells are all in the bloodstream. This is what we have, like we sit here. So this is the bacteria, which is in the bloodstream and is going around, making you sick, actually. But what happens? This bacteria is recognized by immune cells, presented over here, and you see antibodies over there. So what happens when the bacteria goes around the bloodstream, those antibodies find the bacteria, and here again, those eating cells, like we just saw, are able to eat the complex of bacteria with the antibodies. So these antibodies are going around in our bloodstream now, looking for infections, or bacteria, or viruses. They can specifically recognize specific bacteria. So like you also saw in the movie, some antibodies can adhere to one bacteria, but not to another. So there are very specific antibodies. Specific antibodies that were built upon building memory. You have these antibodies, have been having an infection in the past, those antibodies are now present to fight those bacteria. So they adhere to the bacteria, and the eating cells can eat bacteria plus antibodies. So this is how these antibodies work. So very, very important components of the immune system, very important in building memory to prevent you from recurrent infections. So if we dive a bit more deeper in the immune system, you have different, let's say, organs that build your immune system. So we're talking about the cells, we're talking about antibodies, we're also talking about organs in our body. So many of the immune cells and proteins, you already saw in the video, those are in our blood. In the bloodstream, there are a lot of circulating antibodies, circulating immune cells that can directly go to the site of infection once there is an infection. The spleen, very important as an immune system component, because if you have removed your spleen, for instance, because of trauma or surgery, your immune system doesn't work as good as it was. Lymph nodes, you may all know lymph nodes that are present throughout your body. When you have an infection, for instance, an ENT infection, you feel swollen lymph nodes in your cervical region, because that is where the antibodies, where the immune cells are active. When you get an infection, there's expansion of lymph nodes size because of expansion of cells and being active over there. So the immune system is not only cells, but also all kinds of organs. Of course, in the bone marrow, there's where all the immune cells are produced. The bone marrow is inside bones. That's where these cells are formed. So we have heard about the immune system, your normal function, normal production of antibodies, B cells, T cells, but back to the problem that we are encountering in clinical practice. So this is, again, immune cell defects. So depending on where the hole is in the umbrella, there's a hole in the immune system giving rise to problems and infections. So I'm a clinical immunologist, and I see patients with inborn defects. So those are genetic disorders that give rise to immune cell defects. So this is what I see most. People with antibody deficiencies. So probably 2/3 of patients with problems in the immune system have a problem in the formation or function of the antibodies. And also for today, I think this is one of the most important components that we encounter problems in 11q disorders. But of course, the whole in the umbrella can be everywhere. So we also see patients with phagocyte disorders, so cells not being able to eat bacteria, T-cell defects, and any other combinations. But the majority of problems that we see in clinical practice are antibody deficiencies. Again, it's located over here. So the B cells not being able to produce antibodies or producing antibodies that do not function properly. So just a little step outside of scope for today. So antibody deficiencies can be from this disorder, X-linked agammaglobulinemia. Just forget the name, but those are boys, X-linked. So the gene defect is on the X chromosome, only boys are affected. Those are boys that don't have any B cells and don't have antibodies after birth. So they are not able to fight bacterial infections. So generally, these boys present with recurrent severe pneumonia in the first year of life. And these infections may be fatal. On the other hand, you have, let's say, healthy persons with a healthy immune system, normal B cells, normal antibodies, normal antibody function. And there is this part in the middle. So some of the people, they produce antibodies, like over here, the production of antibodies is normal, but the function is low. And some of the patients have lower numbers of antibodies and a lower function of antibodies. So there's a spectrum of disorders, and in one patient, you have no antibodies at all, and the other patient, you have antibodies, but you do not function well. Common denominator, they all have an increased risk of infections because of antibody dysfunction. And you can understand that patients with XLA having no antibodies at all have the most severe infections. What kind of infections do we see? So we're focusing on antibody deficiencies, because that being the most important part of our clinical work and also the most important problem in 11q disorders. So people with antibody deficiencies have recurrent infections, particularly of the upper and lower respiratory tract infections, so ENT infections, recurrent otitis, recurrent sinusitis, recurrent pneumonia, all kinds of upper and lower respiratory tract infections caused by bacteria. Some people may also experience other infections. And maybe you can recognize more or less what's true for your own family. Some people may experience skin infections. Some people may have severe abscesses of the skin or abscesses of the bones. Very severe and uncommon infections in the general population. But most important, and also we should be aware of as clinicians, is when people present with recurrent upper and lower respiratory tract infections, that could be a clue for an underlying immunodeficiency and antibody deficiency. So here in more general, what kind of problems do we see? People being sick. A lot of infections, staying home from school, not being able to work, admitted in the hospital, requiring multiple courses of antibiotics before we see people recover. We're not talking about a flu-like syndrome recovering in 2 days. No, those are people that get sick and stay sick longer than their family members or longer than their friends at school. They require treatment. Instead of recovering by themselves, they require recurrent antibiotics to get them over this infection. And most of the time we see those patients admitted in hospital because of severe pneumonia. Because we all have infections, and we all may have infections multiple times a year. For instance, if you have small children, they go to daycare, they go to school, they can get infections over and over again, most of them viral infections, but those are infections that are not related to immunodeficiency. In case of severe infections, then we should think about underlying immunodeficiencies. And actually, this is a picture of one of my late patients. It was Jiri Schouten, a guy from the Netherlands, and some of you may know him, or at least his parents, because this is the picture. Well, actually, this is the guy that involved me in the field of Jacobsen syndrome at that time, because he was referred to me by a pediatrician with a question. Okay, I see this guy, he's known with Jacobsen syndrome, and he has this hands full of warts. And I should say that at this time, he was already 17 or 18 years of age, so he was almost adult. We see a lot of warts in children, but if this happens, I mean, first of all, these are a lot of warts on the hands, and in adults, warts are very uncommon, because warts are viral infections. And remember, when your immune system evolves, your immune system gets smarter, T cells can fight viral infections, and hence we don't see severe warts at adulthood. So this was the first question related to Jacobsen syndrome that I got in my outpatient clinic. Is there an underlying immune deficiency? Does the immune system not work properly because of this severe warts? And another patient from my outpatient clinic, as an example, this is a chest X-ray of the lungs. This is a normal lung, and here you see this white area is a very severe lung infection, a bacterial lung infection with a streptococcal pneumonia, a very severe lung infection in patient with Jacobsen syndrome. But actually, this started my, let's say, research and also my clinical work here on better understanding of the immunodeficiency problem in 11q disorders. But then I was already quite late, because look at this paper. It was published already in 2004 by Paul, and already describing the clinical problems in patients with Jacobsen syndrome. I think you can clearly see here, I just want to focus on the recurrent infections that in a number of patients, so out of 78 patients, 42, over 50%, it was described that they suffer from recurrent infections. Of course, we know all the other clinical problems related to Jacobsen syndrome, but I think this is quite remarkable that more than 50% at that time was already presenting with recurrent infections. And over the past years, there have been multiple reports. Don't try to read this, but from all parts of the world, there were some cases described with 11q disorders related to an immune deficiency. So patients with low numbers, hypogammaglobulinemia, low levels of antibodies. Also here, combined immunodeficiency, B and T cell problems, so not only antibodies, but also T cell problems have been described. Thrombocytopenia, of course, very common, and immune deficiency from France. So just example that around the world, people were recognizing that immunodeficiency was a problem in Jacobsen syndrome. So given the fact that I saw this patient in the outpatient clinic and reading in literature, I was more and more interested in why do these people have immunodeficiencies, and maybe we could do a large study on it. That was the idea at that time. It was 2014, and a large study in the Netherlands was 6 patients. So I have to be honest, it's not a clinical trial on diabetes, in which we generally include thousands of patients for Jacobsen syndrome at that time. Of course, it's quite a large group. So there were 6 people of which we were able to see them clinically. What kind of infections did they have, and what kind of immune problems did we encounter? Again, those were all people with a defect, a genetic defect in 11q. And as you see here, all of those patients suffered from recurrent infections, recurrent upper lower respiratory tract infections, recurrent otitis, recurrent sinusitis. The main problem being infections of the upper and lower respiratory tract. So what we did, we evaluated the antibodies. Remember those immunoglobulins, which seem to be very important in fighting bacterial infections. And only in 1 out of 6, the level was normal. It should be for adult people above 7. And you see in all the other 5 patients, levels were below 7. So in 5 out of 7, we found low numbers of antibodies. And we also did a functional test because you can have low numbers of antibodies, but if they work very well, you may not suffer from infections. But not only the problem was that the levels of antibodies was low, but also the function of one was low in 5 out of 6. So you have a defect in the production of antibodies, B cells produce less antibodies, and the function of these antibodies that they produce is also low. So it's 1 and 1 is 3, making you more and more immunodeficient. So conclusion of that study was, yes, we see in the majority of our patients in the Netherlands, decreased production of antibodies and a diminished function. So now we have to go a bit more into detail. I just want to show you this slide, not to fully discuss, but one of the important things is that it's like what I already mentioned, our immune system is able to build up memory. And very important are memory B cells. The name already says it, those are B cells, cells that produce antibodies that are able to build up memory. So after an infection, after serious infections, our immune system will increase the number of memory B cells. So like I already said, if you get the same infection 3 months later, those memory B cells produce antibodies that can fight the infection that you had 3 months ago. So memory B cells are very important in building up immune cell memory to prevent you from getting sick from the same bacteria over and over again. So with the knowledge that the antibodies were low, the function of the antibodies were low, we dive a bit more in detail in the B cell numbers. So these were total B cell numbers. These were healthy controls, people from our lab, and you see B cells differ between people. So some of them are a bit higher, some are a bit low, but in general, this is the mean number of B cells in healthy adult controls. What we saw in the 6 people that we included in the study, that the total number of B cells was a bit lower. You could also argue, well, if you look at this one, or this one, or this one even, there are also healthy controls with this low number of B cells. So this was, maybe it was interesting, but maybe it didn't give a clue at all, because these numbers were not very, very low compared to healthy controls. But much more interesting was what we found if we looked at the memory B cells. So remember, the memory B cells particularly important for building up memory and preventing from the same infection again and again. So again, healthy controls over here. Also, a variation in number of B cells. But here what you see in the people included at time of the study, the memory B cells were very, very low. Almost 0 in 5 out of 6 from the patients. So that was an important clue, because those cells, yes, if these numbers are low, that means something. Because that means that you're not able to build up immunological memory like you should. You're not able to produce antibodies to protect you from infections over and over again. So I think it was clear that at that time we found there was a decreased production of antibodies. Yes, the function of the antibodies is low, and there are low numbers of memory B cells, which all fits with the clinical picture of recurrent severe infections with particularly bacterial infections. So I think this was at that time the conclusion. We find people with 11q disorders with severe infections based on antibody problems. So to discuss here today, because what I encountered over the past years is that many people, or many physicians even, are not aware of an immunodeficiency being an underlying problem in 11q disorder. So the question is, how can we diagnose our kids, family members, with an immunodeficiency when needed? I think one of the first things important is you should think about it. Because if you don't think about it, you won't do the tests and you won't get the results on it. And how to think about it. And I think this comes in handy sometimes, because these are what we call warning signs. And different from the Jeffrey Model Foundation, an USA-based foundation originated by the family Model, who lost their son because of a very severe immunodeficiency a long time ago. And these are creating awareness for doctors to think about immunodeficiencies. And just don't want to go into detail, but if you look here, so those are kids or adults with recurrent infections, severe infections, requiring antibiotic treatments over and over again, infections at strange places, or infections with strange microorganisms. So these warning signs are clinically used to think about an immunodeficiency. There is not such as a scoring system, so it's not the case that if you have 2 points, you have an immunodeficiency, or you have 1 point, you don't have an immunodeficiency. But these are quite good reminders for doctors to think about, hey, could it be immunodeficiency, and should I do diagnostics, yes or no? So first of all, think about it, use the warning signs, could be immunodeficiency in a patient with recurrent infections, and should we do diagnostics? And the diagnosis is actually quite easy and very cheap as well, because that's always the case when you go to an immunologist. People think, also in our hospital, also our board of directors think that all our diagnostics are very expensive. But it's not the case, because you can easily start with levels of antibodies, immunoglobulins A, G, and M, IgA, IgG, IgM. So with Jacobsen or Levin-Q disorders, we see that the levels of IgG are low. This will cost you $10 in total. Of course, measuring levels may not be enough, because in some people, like already shown on the figure for patients without antibodies towards patients with antibodies with the decreased function, we also need to evaluate antibody function, because some people have normal IgG levels, and some doctors say you don't have an immunodeficiency because the levels are all normal. You should say no, you are not right, because it could be that the function of the antibodies is still not good. That's a bit more complex, because then you need to do a vaccination test. What is a vaccination test? We measure antibodies at this point. We do a vaccination, and we tend to use pneumovax vaccination, so Streptococcus pneumoniae bacterial infection vaccination. And after 4 to 6 weeks, we measure the response. In a normal situation, if your antibodies function well, after vaccination, you get an increase in antibodies, right? But that's our goal of vaccination, an increase in the levels of antibodies, protecting antibodies. What you see in people with disturbed antibody function, nothing happens, or you see a slight increase of the levels of antibodies, but it's not enough. So this is a very important test to measure function of the antibodies. Measuring antibodies, vaccination, 4 to 6 weeks later, you should repeat the measurement to see whether there is an increase in the antibodies. And that's actually all we should do. Of course, you can measure B cells, you can measure memory B cells, but then sometimes the question is it possible? Because not all labs can evaluate memory B cells. It's more expensive, but the question is, do you need it to get the diagnosis? Evaluate immunoglobulins, evaluate immune cell antibody function by vaccination. Those are crucial steps, I would say. And if you want to better understand the underlying defect, you can measure B cells or memory B cells. But for the diagnosis or for the treatments, it doesn't matter. It's not important. So let's say if you have someone, so this is a picture from a patient of mine at the outpatient clinic. If you have a patient with recurrent infections, you have the diagnosis of an immunodeficiency, an antibody deficiency, what could you do? Of course, be aware of infections. Because, like I said, the patients have recurrent infections over and over again. So you have to treat them with antibiotics. If I have a fever, I go to bed, stay in bed for 2 days, and hope I get better. But in patients with an antibody deficiency, if they get fever, you have to directly check what kind of infection is going on, and if needed, start antibiotic treatment earlier than in people with a normal immune system. Because those patients are more vulnerable, get more sick, have the risk to get admitted to the hospital. So earlier treatment should be at least considered. Secondly, if patients get recurrent infections with the same bacteria, you can decide to prescribe prophylactic antibiotics. They take a pill of antibiotics every day to get them protected against recurrent infections. Of course, and maybe some of you may recognize it, these are pumps that can give you immunoglobulin substitution therapy. So patients, they have low levels of antibodies, low levels of immunoglobulins, and you can collect immunoglobulins or antibodies from healthy plasma donors, and those people get regular infusion of antibodies, not to make them better or improve the immune system function, just to support the immune cell function by increasing the levels of antibodies. So instead of their own poorly working antibodies, they get healthy plasma donor antibodies to prevent them from infections. And actually, until now, those are the only treatment options available if you have antibody deficiency. But this works in majority of people. So we see and we know and we found that a lot of people with 11q disorders have infections, which is related to antibody problems. But then still, I was thinking, and if you listen to me carefully, I was constantly saying that patients with antibody deficiencies particularly suffer from recurrent infections with bacteria. And remember the picture on this slide on the screen showing the guy with multiple warts. That's typically not an antibody-related problem, because for warts, you need T cells to fight warts. So the question is this antibody deficiency the only thing that we see in 11q disorder, or is there more to explore? And this is actually Dr. Huisman. She's a pediatric hematologist, in particularly specialized in thrombocytopenia in pediatric patients. But she was also seeing those patients with Jacobsen disorder, having those bleeding disorders, and she was actually interested into finding out what is going on with other cells in Jacobsen or 11q. So we collected data from a larger part of the Dutch Society of 11q disorder patients, just to show you that, as you know, there were different genetic variants available, because we are trying to find what kind of disorder is found in immune cells, and could it be related to specific genetic defects? Well, that would seem to be very difficult, but what we found, if you look here, just to show this, this column, this was T cell function. So in the majority of patients included, you see that the T cell function was inadequate. So T cell function necessary to fight fungal infections on one side and viral infections, that in majority of 11q disorder patients, also T cell function was hampered. Apart from B cell problem with antibody formation problem, but also a problem in T cells in the majority of people, which could explain the increased risk of viral infections or even fungal infections in some people that we see in clinics. So there is indeed more to explore, because it's not only B cell problems, but also the T cell problem, which makes you more vulnerable for infections. One of the things that still puzzles us is, why is there an immunodeficiency in 11q disorder? Well, I don't have to explain you, of course, that there is a genetic variant affecting different sized parts of the chromosome 11. And what we know until now, there are 6 genes on chromosome 11 that were found to be related to immune cell disorders. This is an update from now. But we see over and over, over time, we get to know more about the immune system every year. So this figure could be different in 5 or 10 years from now, because we learn more about the DNA every year. But at this time, these are genes located on different parts of chromosome 11 that could be related to immunodeficiency. And of course, one of the important genes is ETS1, which is of course also involved in cardiac problems, which may also be related to immune cell defects. But this is still a big question mark. What gene is responsible for the immune cell defects in 11q? And this is something we need to explore in more detail. So for this part, I have some conclusions. I think it's definitely shown that the majority, I would say, of people with 11q disorders suffer from recurrent infections. Something that we all see in clinics, you all may encounter in your own families. One of the particular problems is the low levels or low numbers of antibodies. and a disturbed function of those antibodies. So on one side, you don't produce enough antibodies, and also the function is hampered. This explains the increased risk of infections. And I think, and with me also Ken, with whom I always give this presentation, we feel that all patients with acute disorders require immunological evaluation. Because in the majority of people, we find clinical problems, and we also find biochemical or immunological problems. So I think it should be included in evaluation of people with acute. And very important, it's also something that I've still heard that's not happening everywhere. Treatment should be at least considered. Antibiotics in case of infections, prophylactic antibiotics in case of recurrent infections, or even antibody infusions in case of severe infections. And I think there is a but in this, and that's something that you should advocate to your doctors, because like I said, some doctors say if you have your immunoglobulins checked and they are normal, you're okay. You have no immune deficiency. That's not true. So levels are just levels, numbers are just numbers, doesn't tell you anything about the function. So these functional tests, if of course, if you have an IgG level, antibody level of 1, it should be above 7, then maybe you are not. Then a low number, most of the time it means low function. But if the function, sorry, if the level is normal, functional defects should be tested for, because some of them may have normal antibody levels, but the function is disturbed, and you still have a problem with your immune system. So really, if required, perform those functional tests. And I think one last point, sometimes we don't find anything. Do testing, you find normal immunoglobulin levels, functional test is normal, and still you have a kid having infections over and over again. So officially there is no immunodeficiency, but if you have the clinical picture of recurrent infections, there may still be something wrong that we don't know by now. So that's also something to keep in mind, because some of people get tested once, they're all normal, and then they are discharged and never seen again with the immunologist. But sometimes you have to repeat those tests after a few years or many years, because our knowledge increases. What we cannot find now, we could find 5 years ago. So I always advocate that indeed, consider retesting after a few years. And of course, if clinics change, if you get more infections over time, also that can be a reason to retest after a few years. So these are things you need to get back to with your doctors if necessary. So just a very small topic I would like to address very briefly is what about immunizations? Because I think over the past years we have a lot of discussions about the need of immunization or vaccination during the COVID pandemic that we have been into. And what I would really like to show you some examples or some things that I find very important to consider if we're talking about immunization or vaccination with disturbed immune cell function. So in 2021, when vaccinations became available in the Netherlands at that time there were some studies describing the effects of COVID-19 vaccination in people with underlying immunodeficiencies. But there were some small reports giving insight into the potential effect of vaccination in patients with antibody deficiencies. And at that time, we decided to do a national study in the Netherlands, including primary immunodeficiency patients. Those were not acute disorder patients, but people with B cell problems, T cell problems, combined immunodeficiency, B and T cell problems. And here you see CVID, XLA, this one all from the spectrum that I showed you before. So the majority of people included in the study were patients with antibody problems. Because one of the concerns was when vaccines became available, those don't work for people with immunodeficiencies because they are not able to produce antibodies, or they do not have proper T cell function. So why bother about vaccination in these patients? So what we did, and don't try to read this terrible picture, but just as an example, so these were control patients patients without an immunodeficiency. We're looking at antibody responses. So you see the majority of people responded very well. This is not a surprise because most people with a healthy immune system, given after vaccination against COVID-19, they have an increased level of antibodies. But what you also see in those patients who produce antibodies quite poorly themselves after vaccination with mRNA vaccines, I have to say, you see that the majority of patients are able to increase antibodies. There's an antibody response, even in the patients that do not produce the normal levels of antibodies. Yes, there are people that do not produce antibodies at the vaccination, for instance, XLA patients. Remember, those don't have B cells. Those will never produce antibodies, so that's not surprising. The majority of other people tend to produce antibodies. And also, in patients with immunodeficiencies, T cell response here, normal individuals, and also people with immunodeficiencies, the majority of people have a normal T cell response. So the conclusion of this study was that the majority of people with an antibody deficiency or an antibody and T cell deficiency, despite them being immunodeficient, responded quite well from an immunological point of view to vaccination after COVID-19 vaccination. As mentioned over here. So yes, XLA patients, they will never produce antibodies, but they have a normal T cell response. So even in XLA patients, vaccination could be of added value because of the induction of T cells. And in other antibody deficiencies, those were quite well. Just very briefly, what we see, and that's also important in general, if you get vaccinated, like here, control patients, after a period of time, so this was 6 months later, you see antibodies decline. That's normal. You get a vaccine, antibodies increase, and after some period of time, your antibody level drop. And also with the patient with the diseases, it was the same. So it was not that they lose their protection quicker than healthy population. It was comparable to healthy population. And then in the healthy population, we did a booster vaccine. This is the first vaccine response. Antibodies go down over a period of time. And then after a booster vaccination, you see an increase in antibodies. And that's also what we saw in all the patients with the disease that we are seeing in clinics. So concluding that despite those patients being immunodeficient, not being able to produce antibodies quite well, or have a diminished T cell response or diminished T cell function, upon mRNA vaccination against COVID-19, we saw that the majority of patients with antibody deficiencies and combined immunodeficiency responded comparable to the healthy population. So I think it's still important to think about vaccination in patients with immunodeficiencies, including patients with 11q disease. But there has been a lot of debates, at least in the Netherlands, about those patients having an immunodeficiency. At specific times, there were shortages on vaccines, and then it was thought, well, maybe we should not use the vaccine because it probably won't work, but it probably does work because we see it in the numbers. We also saw in clinics. So after initiation of the vaccination program in patients with immunodeficiencies, we saw a decline in hospital admissions because of COVID-19. So it works from a number point of view, but also from a clinical point of view. So I think considering or thinking about vaccination is important, and I think it should be done. So that's the last slide on concluding on the vaccine response. So yes, vaccine response is different between various groups of patients and diseases. But what we found, what was quite important, that the large proportion of patients with immunodeficiency responded well after vaccination. Then the question, of course, is it enough? Because you see the numbers of antibodies increasing, you see the numbers T cells increasing, but does it also provide protection? Yes, and that's what we thought because we saw less hospital admissions. The only argument I would make here is that, of course, the first wave of COVID-19 was very bad. And a lot of people came into hospital because of severe disease. And once we started vaccinating, those people, the second or third wave was already there, and the disease severity of COVID-19 also declined. So did we see less patients in hospital because of vaccination or because of the natural course of the virus? Well, that's something why I put a question mark here, because we will never. Finally, I would like to thank, because maybe on the research topics that we did was in close collaboration with many people from the other academic hospitals and with the patient organization in the Netherlands. And with that, I would like to thank you for your attention.
Take a few questions.
Yeah.
My question, and two questions. The first being, so our daughter has been followed by immunology at Boston Children's Hospital since birth. They followed her through all of her childhood, early childhood vaccinations, and then kind of the conclusion was the clinically definition was she had a wonky immune system.
Technical term.
It's the technical term, yeah. So in some areas she's fine, and others, and so that's kind of what we've carried with us. It's wonky, but she seems to be pretty typical, and she doesn't have a lot of severe infections, but she gets sick very often with these upper respiratory things. Just a few weeks ago, she was home for 5 days from school. And it never turns into anything super serious. So we don't get we don't have antibiotics, and then if you take them into the doctor, they're just like, oh, it's cold, it's a virus, there's nothing that really can be done. So in seeing your slide about treating earlier prophylactically and with antibiotics, is that going to do anything if it's just a virus? Like, how do you determine, because it would be great if we could give her something so that it's a shorter duration, but I feel like we just have to kind of grin and bear it as long as it decides to go. And then
Yeah, so the first question, yeah, the problem is, of course, if you give antibiotics in case of viral infection, that won't work. Yeah, so that's, of course, the question always, if there is an infection, the question is it viral infection or is it bacterial infection? Well, how can you see? Well, you can take cultures if that's possible. You can draw blood to test for culture for bacteria, yes or no. Or most of the time, of course, a clinical picture shows you or direct you towards what it is. And yes, I agree that I think a lot of upper and lower respiratory tract infections are caused by viral pathogens, and then in that case, antibiotics won't help. The problem that and the increased risk of viral infections is mainly to do with the waning T cells, I think. The problem is that we sometimes see that it starts with a viral infection, and then the patient with immunodeficiency, a viral infection, let's say there's a super infection by a bacterial microorganism, and at that time, antibiotics can or should be considered. But in the beginning, if it's recurrent viral infections, there's probably nothing. No. The question is, like you say, is it really severe? Is someone admitted in hospital, yes or no? And if that's not the case, then for viral infection, you cannot do more than that. Yeah.
And then the second question is it possible to have an immune deficiency or wonky and also have an autoimmune disease? Because she is being evaluated for chronic recurrent multifocal osteomyelitis, CRMO. So she has a lot of inflammation and pain at various points in her body that gets quite severe sometimes and then will completely go away. But because of her platelet dysfunction, she can't take, the NSAID Advil, basically, or ibuprofen would be the first line. She can't do that. And then steroids because of the immuno stuff. So they're very hesitant to make a final diagnosis because there's not really a good way to treat it. So is it even possible that she could have an immune deficiency and on the other side, too much immune response?
Yeah, so it's a very, very important question, and I think we can discuss for another 45 minutes because it's a very complicated problem. And I think one of the slides showing the balance that we see sometimes in people with, actually in many times in people with an immunodeficiency, they have an immune deficiency on one side and autoimmunity on the other side. So very briefly, what we think is one of the problems. So it's a hypothesis that we have worldwide. So those people have low numbers of antibodies, right? So low antibodies are low, not enough protection, recurrent infections. But in patients that have low antibodies, but antibodies are detectable, we think and we know that a significant proportion of those antibodies are what we call autoantibodies. So they are low, do not function well. That's what is causing infections. But the proportion of antibodies that is left, a higher proportion of those antibodies is autoimmune antibodies. But those antibodies do not attack viral infections or bacterial infections. Those are attacking part of the immune system of your own body. But that's a very common feature. For instance, in children, autoimmune cytopenia, so breakdown of red blood cells or white blood cells or thrombocytes, those are very commonly presenting symptoms of immunodeficiency. So those kids go to the doctor because of anemia or low numbers of thrombocytes, because of autoimmune thrombocytopenia, autoimmune anemia, so the immune system breaking down these cells, but they were found to have an underlying immunodeficiency. So those people indeed may have infections, may have autoimmune problems. So if you remember on the left bar, those patients with XLA, so those are boys that do not produce B cells, do not produce antibodies, you don't see autoimmune disease. Probably because, well, they have no antibodies. So they have infections, but they also have no antibodies that are fighting their own body parts. Yeah, so indeed, long answer, but the short answer is yes, we see it very regularly that people suffer from immunodeficiency on one side and autoimmunity on the other. Oh,
Should I shout or should I come up? Come up?
yeah, you can shout and I can repeat for
Yeah, perfect. Can you speak to whether or not there are any clinical interventions addressing the T cell deficiency?
yeah, so Paul asks whether we should focus on problems related to T cell deficiency. And you think regarding treatment, for instance, right? Yeah, so the problem is like, well, answering the question that just came across, that T cell deficiency in those patients tend to give recurrent viral respiratory tract infections. We see the wart infections. So treating or preventing those infections is something that we still find quite difficult. There's a lot of debate in the Netherlands, so I don't know how it's here, about vaccination, vaccination against viral infections, for instance, RSV viral infections, or even HPV viral infections, because these are warts caused by HPV, which HPV may also cause cervical cancer at a later stage. So now in the Netherlands, we have this national program of vaccination against HPV. And the question is, in immunodeficiency patients, should you give repeated vaccination? So if you're talking about doing something about the T cell defects, I think one of the major challenges for the coming years is thinking about what kind of vaccines can we implement to prevent recurrent viral infections. But we only have, of course, limited availability of vaccines targeting or preventing viral infections.
So it's really aimed at a specific viral etiology.
Exactly, yeah. So then you vaccinate against RSV, you're vaccinated against HPV, you're vaccinated against COVID, but it's all one
But
viral.
nothing like colony stimulating factor or anything like that.
Yeah. Yeah, that's very interesting. So can you stimulate T cells in functioning better? So can you generally increase T cell function? Well, there have been many years ago, there have been studies in HIV. Of course, HIV in immunodeficiency caused by a virus, which breaks down your T cells. And there were some studies trying to, let's say, improve the function of the T cells with, for instance, interleukin-2, which is a T cell stimulator. But those medications tend to have very many side effects. So those studies were stopped because of the side effect. But yeah, so from, let's say, theoretical point of view, increasing T cell function should be the way to go, but the question is how. So for just to, because in patients with, let's say, very severe T cell function, so sometimes we see kids that are born without B cells, without T cells, then hematopoietic stem cell transplantation, of course, is the only way to cure the defects. But of course, also very risky procedure. With those people without B cells, without T cells, that's the way to go. Yeah.
Thank you, Virgil.
Yes.
I wanted to ask both you, Dr. Paul, as well as you on the immuno side, when you have patients with these chronic irritations of the immune system, say chronic RSVs or the multiple COVIDs, and the ongoing cell deficiencies of cell function, is studies being done on I don't know, preparation and plans on how that kind of progression affects them?
So the question here is how progression or recurrent viral infections again and again affects
Functionality of the organs.
functionality of as well. So that's, yeah, it's a stupid answer maybe, but it depends on the severity and the number of infections that you may have. So if you have, for instance, recurrent central pulmonary tract infections, let's talk about recurrent pneumonia, either viral or either bacterial, it may result in organ damage. Because if you have an infection, you may recover clinically, but sometimes, for instance, in pneumonia, there is some damage to the lungs, which can be irreversible. And if you have infections over and over again, the chance that it becomes irreversible increases. But that's something that we need to check up. You cannot prevent damage from recurrent infections other than preventing the infections. But yes, depending on the size of the infection, depending on the number and severity, and also the cause of the infections, you may have or you may develop damage to specific organs. And particularly bacterial infection of the lungs are, I think, the most important infections that may give rise to irreversible organ damage.
And if you were watching for that from your perspective, would you look for statin or just lung function in general? Or
Yeah, so
follow with pulmonology to see what function is and maybe get a baseline?
yeah, so the question is, what should we do for checkup to evaluate for organ damage? So for instance, in, let's say, all patients with primary immunodeficiency that we see, majority of patients suffer from recurrent pneumonia. So they get a CAT scan and pulmonary function test at a regular basis. So the consensus in the world, for instance, in patients with immunodeficiency, that you get a lung function test every year and a CAT scan at least every 5 years. Also depending on the age and depending on previous scans, of course, just to follow up. But because also we see sometimes that patients do not suffer from very severe bacterial infections, but still they may occur some lung damage. Yeah. So we should take care of that. Yes.
The first lady that asked a question alluded to something with regard to steroids not being administered, not being administered both in some conditions. But I'm curious about the steroid interaction.
Yeah, so the question is related to the first question, the discussion about steroids in the use of steroids in people with immunodeficiencies. To be more general, like I just explained, sometimes we see autoimmune disease in patients with immunodeficiency, and if it is necessary, we treat with steroids because we treat what we think we should treat. Yes, when you give steroids, antibodies will go down. If you treat with steroids, T cell function goes down. So if we need to, we give steroids, but we know that we hamper the immune cell function. So we are aware of an additional effect, negative effect on immune cell function, an increased risk of infections. But sometimes we need to, because we have to keep that balance. Yeah, and then we sometimes, if we treat those patients with steroids, we give them prophylactic antibiotics to prevent from infections. Or sometimes if we see that the immunoglobulins go very low, we treat them with immunoglobulins when necessary. And then sometimes you have to play with the medication to keep that balance. Yeah. So it's not prohibited to give steroids, but be aware of the increased risk of infections. Are you short because Paul was walking?
No.
I
No,
think you
no,
are finishing.
you can have the whole day.
I just have a quick COVID question with a healthy, B cell component antibodies, and then they get COVID. As new variants come around, is it so, memorizing or remembering a component of the COVID that they got that lessens the severity with the mutation as per the mutations?
Yeah, so that's a very important, very difficult question. I will repeat it for online. So the question is, when you get recurrent COVID infections, in this example, will your immune system have some memory based on previous? So yes and no. First of all, it depends on what kind of infections we're looking at. If we look typically at COVID-19, what we see that until now, the majority of new variants, or no, let's say the other way around, so the immune system shows some cross-reactivity against the different variants. So after vaccination, because vaccinations also change over time, so after vaccination or after COVID-19 infection, your immune system builds a memory, and of course new variants arise, but we know that some antibodies based on previous infections, previous vaccinations, cross-react with the new variants. So when new variants pop up, there is some defense against new variants based on prior vaccinations or previous infections. But of course, the protection is not as good as giving a new infection or vaccination. But there is, at least until now, still some response. Yeah.
I want to kind of circle back to what you were talking about, so I can think forward planning for, flu season coming. During the summer season, we'll have high asthmatic, reactions, sometimes resulting in steroids. I can think of 3 episodes that resulted in pneumonia severe, hospitalization shortly after. Is that kind of the correlation of throwing off one system and setting another, and then how do I present this situation or weigh the clinical choice options in the episodes and be prepared for what might be the next step, whether we can create that deficit?
Yeah, so the question is, in case of a specific example, exacerbation of asthma and pneumonia. And the question, of course, is it related to the immune cell defect, yes or no? Because also in general, when people have asthma and they have a normal immune system, having asthma exacerbation may also increase the risk of infections because your lungs are more vulnerable for infections. So more particularly in people with asthma and immunodeficiency, there is an even more increased risk of developing infectious complications. Yes, so you should be aware of that disbalance, and if there is an asthma exacerbation, consider, or if you see repeatedly that it ends up with a bacterial infection, you should consider, or could consider treating earlier. But it's always finding the balance, because if you start treating asthma exacerbation with steroids, again, because that's of course what we do.
Bigger doses.
If you have an immunodeficiency, the risk of an infection, which is already increased in asthma exacerbation, may even get worse. Yeah, so that's something that you really on personal way discuss with your treating physician to see how can, because it's always difficult to find balance, because we are talking about problems that are on both sides of the spectrum, from immunodeficiency to autoimmunity or autoinflammation. So the immune system gets overactive, and somewhere across that line, you have to find your personal basis, and which for one person could be completely different than for someone else. That makes it difficult, also for treating physicians, to find that balance. Yeah. I have only one. Yeah. You can use it.
Thank you.
So to piggyback on the asthma question, my son was diagnosed with asthma and given the flow vent, I think it was called, and the albuterol. They assured me it was the very smallest dose possible, and that really, if you were to add it up compared to a dose of, say, prednisone, it was significantly lower. So would you be concerned with that level, like those little puffers that are, you know, because he does then wind up with many ear infections throughout the year. So I don't know if it's related.
Or even Wexler's dosage. It started at brand Wexler.
Yeah, so the question indeed about the effect of steroids by inhaling. In general, the negative effect on the immune system function is very limited. So if you take steroids by pills, by infusion, you see a direct effect on the immune cells. And if you do it by inhalation or ventilation, the effect on the immune system is limited. But we also thought about people taking creams, for instance, for skin problems containing steroids. Was always said, well, that's only local, so there's no effect on your inner body. But we know now that also people have a lot of skin problems and use creams containing steroids a lot. It has an effect on not only the immune system, but also on other functions in the body. So in general, I would say inhalation of steroids has small effects, a very limited effects, but we cannot rule out any effects.
All right, I think we're safe.
Yes, thank you.
And here, I know that Virgil has very graciously offered to meet with many of you individually. As Lizzie said, if you haven't signed up already, I think there are still a few opportunities.